So thank you all so much for joining us for tonight's program on measles. The Public Health Museum is delighted to partner with the Tewksbury Public Library and its affiliates to continue the series Behind the Headlines as we dive into the topic of measles. Previous programs in this series include bird flu and fluoride in drinking water discussions. Tonight's panel includes Louis Fazen, pediatrician and founder of the Global Health Committee at the Massachusetts Medical Society, and a former faculty member at UMass Chan Medical School. Elena Conis, who's the acting dean of the UC Berkeley College of Journalism and author of Vaccination. Scott Podolsky, professor of global health and social medicine at Harvard Medical School and director of the Center for the History of Medicine at the Countway Library. And finally, Hillary Johnson, senior epidemiology advisor to local health for the Massachusetts Department of Public Health. And so, folks, let's give a big virtual round of applause to all four of our panelists. And Louis, you can take it away.
Oh, thank you very much, Robert. And also to the Tewksbury Library and the Public Health Museum in Tewksbury for hosting this conference this evening. There are many exceptional speakers here tonight, and I am going to focus in on my career as a pediatrician, which began in the mid-60s. That's exactly when the measles vaccine came out. So it's measles, and the measles vaccine has been with me for my entire career. And most of the cases and most of the disability and the mortality from measles is in childhood. But I wanted to just describe a little bit of how contagious measles is and a little bit about the vaccine, because most of the vaccinations are given in a pediatrician or family practice office. And there are also some, and certainly many primary care centers and probably a few public health facilities also administer vaccines. So let me just present a hypothetical situation, and you're having a party for a friend who's just come back from Paris, could be Paris, Kenya, Philippines, and has symptoms. And these are some of the early symptoms of measles, but they could be confused with just jet lag or other problems. A cough, fever, which isn't too bad, it's just been around for a day or two, runny nose, and some red eyes. Both eyes are red, and that again could be part of the flight, the long flight. The friend really would have been better to stay home with those symptoms, especially after a long trip. And just to point out that nowadays the travel part of measles is more directed to people from the United States who are traveling abroad and may pick up measles there. And versus 10 or 20 years ago, it was much more likely to be people from other countries who are coming to the United States, maybe, and go to Disney World or someplace where they might spread measles. So this friend has come over. There may be 8 or 10 people around with that cough, fever, runny nose, and red eyes. These are the early symptoms of measles, and these are present about 10 days after exposure. So the main point here is that the rash is not present, and it's hard to identify measles without that rash. And it's a very typical rash. It starts in the head, forehead, and face, and then it moves down and moves south, and it goes to the trunk and then to the extremities. So it's something that becomes pretty obvious when that rash is present. And there's also some white spots in the back of the throat about that time. But that's going to occur maybe around day 4 or 5 of this. The prodromal symptoms are already present, and the person is already contagious to other people when these prodrome symptoms are present, and the rash is unknown at this time. So time is spent 3 or 4 hours together, and there's some laughing and carrying on, and the cough is present throughout the whole time together. They're talking about this trip. Well, the problem now is going to be this person is going to come down in the next day or two with the obvious measles, and the question is, how did what chance do people have of this spreading to those at the gathering? And it's about a 90% chance that people will spread. It's spread by droplets. These are hanging in the air and people are breathing, and there's a 90% chance that people who are not immunized are going to come down with measles. So it would take 10 people. One of those is probably going to, if it's not immunized, it's going to be able to spread that disease. And that becomes, and when the diagnosis is made, it becomes a public health issue. It's a reportable disease, and Hillary Johnson's going to be talking about that. What happens when the public health is involved? And you might ask, is there some particular treatment or prevention, some other way to prevent it besides the vaccine? And we're very limited in that regard. It's sort of the same, if you know that you are sick, it's the same kind of precautions we had with COVID. Cover your cough, stay home if you're sick, wash your hands well, take care of yourself if you're sick, wear a mask if you're in contact with other people if you're sick. So that's pretty much the same. Vitamin A has been discussed, and that has worked in population studies and in other countries where there's vitamin A deficiency. So it is not shown to be a strong help at this point, and there is some problem with vitamin A because if too much vitamin A is used, it can be toxic. So, and we also do not have a specific antimicrobial, a viral antimicrobial for measles. So the best thing at this point is the vaccine. Well, let me talk about the vaccine, and it's actually a three-part vaccine, and it came out with measles, mumps, and rubella, and it came out in the mid-60s. And at that time, I thought this data was really interesting. And at that time in the mid-60s, about 40 to 50,000 people a year were hospitalized with measles in the United States, and about 400 to 500 people died each year from measles. So, and many of these again were young people, young children, and healthy people who had a long lifespan ahead of them. So, when you look at the year 2000, we thought that we had measles under control and we had it eliminated. It took about 35 years from the time the vaccine was presented to almost no deaths. It's very rare now to hear about a death of measles, and 400 to 500 people dying each year before that vaccine. So that's a strong indicator about the value of the vaccine. And so I think I'm just going to leave with that pediatric note that we vaccinate people in the office, young people, and it takes 2 shots, and it's amazing. It lasts 65 years so far, 45, 50 years so far. So it's a very good vaccine. There are very few reactions. Yes, some children do get some fever. They can get a little rash. It's rare to have a very high fever, and sometimes with a very high spike in fever, there can be a seizure, which is usually a one-time event. So the reactions are very limited. I think most pediatricians the vast majority of pediatricians are very forceful about immunizations in the office. So let me leave it at that and turn this over to Dr. Podolsky and Elena Conis. Thank you.
Thanks so much, Dr. Fazen. And I think we hopefully in this conversation I'll have with Dr. Conis, we could use this as an opportunity to go from measles to measles vaccination to really using measles vaccination as an exemplar to speak about modern vaccination more generally. And your book, Vaccination, is fantastic. And to some extent, there's been enduring tensions about vaccination ever since the advent of smallpox vaccination at the end of the 18th century. But since the introduction of the measles vaccine in the 1960s, things seem a little bit different. Can you frame some of these changes for us?
Sure. Thank you, Scott, for that question. And actually, to set it up, I'm going to rewind the clock a little bit to the beginning of vaccination, which you just referenced a moment ago, just to give people a kind of big picture sense of where we're at. The first vaccine that we developed was the vaccine against smallpox in the late 1790s. And we lived in the US in pretty much a fairly consistent era of vaccination for the next roughly 100 years. Over the course of the 19th century, local boards of health gave more and more authority, or local cities gave more and more authority to local boards of health to pass vaccination mandates, but we didn't use mandates very widely until closer to the turn of the 20th century. And then in this country, more and more states started to pass laws or regulations that required people to get vaccinated either in the context of an outbreak or in order to enroll in school. And so we had a big, pretty tense conversation about mandates in the late 19th century, early 20th century. And that led to some pretty spirited debates at the state level, and then also one case that made it all the way to the Supreme Court. For the first half of the 20th century, public health officials kind of pulled back from mandates again. And now this is going to get us all the way to the second half of the 20th century, where we started to use mandates once again. So as you can see, like for the first 150 years of vaccination, we kind of went back and forth between mandating vaccines and not mandating vaccines. But what changed with the advent of the measles vaccine in the early 1960s, which Lewis referred to, was that at that time, we had just experienced how powerfully vaccines could control an infectious disease with the advent of the first polio vaccine, and then the second polio vaccine, and the first measles vaccines developed in the 60s, based to a great extent on the technology that enabled us to create polio vaccines. These measles vaccines seemed like they held the promise to control measles as well as we had controlled polio. But what happened was the US public didn't show the excitement for the measles vaccines that they showed for the polio vaccines. So people didn't rush out and get them, and governments, state governments and the federal government didn't put as much support behind measles vaccination as they had behind polio vaccination. So the measles vaccines raised all of these new questions. How do we vaccinate in this new era where we have the capacity to produce vaccines that we never had before? To kind of make a very long story short, what happened next was that folks working in public health started to show that mandates were a really effective way to control vaccine preventable diseases like measles. And so we started to increasingly turn back toward mandates. We also got more support from the federal level following the polio model, with the federal government encouraging states and providing states with more resources to encourage widespread use of these new vaccines like the measles vaccine. But measles represented a really important shift, and this will be maybe the last point I make about this era. Polio and smallpox were diseases that the public was kind of uniformly afraid of. And so they turned out for those vaccines. They feared them. And when those vaccines became available, they sought them on their own. As I mentioned a moment ago, in the 1960s, immunization experts and officials and family physicians were all very enthusiastic about the measles vaccine, but measles by the public was seen as a categorically different disease from polio, smallpox, even other vaccine preventable diseases of the time like diphtheria. The attitude on the part of the public was, measles doesn't seem so bad. It's just a part of childhood. So, okay, maybe I'll get the vaccine for my kid, but it doesn't seem so urgent. So this was a real important shift in the kind of history of vaccination.
Thank you. Thank you for those implicit shout outs to Massachusetts. We had,
yes.
We had Jacobson versus Massachusetts. There's this
that Supreme Court case originated with you guys. That's right.
Right, in the early 20th century. And we're going to somebody take credit for the propagation of poliovirus and tissue culture that won the Nobel Prize with John Enders and Thomas Weller and Frederick Robbins. So we'll make the local plug for folks to come visit the museum to learn more about all this history.
Oh, good.
Yeah. So within all that, what in recent decades, and this is obviously a huge question, but what have been some of the major forces shaping vaccine uptake and also vaccine resistance?
Right. So let me focus on uptake first. So if we look back again to the kind of new era of vaccination that got going in the 1960s, it was really critical to have federal support in place to encourage vaccine uptake from that point on. And again, the polio era had kind of demonstrated how valuable federal support could be. And I mean support, kind of verbal support, political support, and also financial support from the federal government to states. This was really, really critical in the latter half of the 20th century. Another aspect which often gets overlooked, but another aspect driving vaccine uptake in the late 20th century was messaging and marketing that didn't necessarily talk about how dangerous and severe the diseases were, but how they had all of these other ancillary benefits. This was an era in which more women were going to the workplace. And so there were women's magazines, for example, talking about how if you needed to stay home and take care of your kids, you weren't going to be able to go to work. Who was going to watch them for you? Get them vaccinated so you didn't have to stay home from work, so they didn't have to stay home from school. There were even articles elsewhere in newspapers about how, get the tetanus vaccine so that, getting poked by a fishing hook on your camping trip doesn't ruin the whole trip. Vaccines were sold as kind of this way to live a hassle-free modern life. They were also increasingly sold as a way to ensure that US-born children were experiencing the best that American science and medicine had to offer. And you could literally go back and see in some of the promotional materials language which, by today's perspective would be offensive, but language that said, like, don't risk mental retardation, get your children vaccinated against and they called them the mild diseases at the time. Measles was considered a mild disease, and that was some of the language used to promote. So there are these cultural reasons, and then the last kind of driving force was a set of economic reasons, that it was a lot cheaper to prevent a case of measles or mumps than to actually have to deal with the consequences of a severe case. And this encouraged states to invest in promoting vaccination. And so that also is important to add to this list of factors that encouraged vaccine uptake. That would change by the turn of the 21st century, but maybe that's where we're getting next.
um, and how about, do you want to talk about resistance?
Yeah, so resistance becomes really interesting in this moment. But before I talk about the kind of modern moment ushered in by the measles vaccine, I do want to go back to the very beginning of vaccination to make one important point. Vaccination resistance has always been with us. As long as there have been vaccines, there has been vaccination resistance. So throughout the first 100 years of vaccination, there were three key forms of resistance. People objected to the smallpox then vaccine because they feared the risks that it carried. And actually, smallpox vaccination was fairly risky by today's standards in the early century of vaccination. So they feared the risks. Many objected to vaccination on the grounds that it conflicted with their religious beliefs. And then increasingly, as we relied more on mandates and the force of law and the authority of government to promote a vaccinated population, people in this country mounted an argument against vaccines that was borrowed from European nations. And this was a rights-based argument. And they argued that it was an individual's right to decide what medical care to get and when, and that therefore these laws and regulations were an infringement of a set of rights that they believed the US Constitution had been created to protect. So these are age-old objections, and by the time we get to the kind of modern era in vaccination in the 1960s, folks start kind of reviving some of these old objections and also adding new ones. And I'll point out to kind of two key ones that get added in the modern era. We still have concerns about risks. We still have concerns about rights. Religious ones get supplanted by kind of more personal belief and philosophical objections. But then there are also a new set of vaccine objections that start to circulate that are informed by the counterculture of the 1960s. And as a historian, it was really fascinating for me to find and document how some of the language of the counterculture movements, like the women's movement and the women's health movement and the environmental movement and the disability rights movement and even the consumer movements of the 60s and 70s, started to encourage some folks in this country to say, well, wait, are these vaccines just corporate tools? Are they just meant to make profits for big corporations? Are they contaminating our body with chemicals that we're not being informed about? And they're also asking questions like, can we have informed consent to vaccination? Do we have enough information about their risks in order to make an informed decision, particularly about vaccines against the so-called mild diseases?
I cannot believe how fast a lot of time is going.
I know.
But your work has done fantastic. You and your work has done a fantastic job of pointing to both those enduring tensions, but also forcing us to consider really all the local context at any given time, politically, socially, culturally. That's really been a valuable lesson. As a final question, you're of course the acting dean of a major school of journalism. What role has the press played in both promoting uptake and in fomenting resistance over time?
Yeah, this is such an important question, and it's a question that we have to answer very differently today than we would have even 10 years ago. And the press has long been both an important partner to communicating the importance of vaccination and an important venue for communicating ideas that have fueled vaccination hesitancy and resistance. And this has been the case for more than 100 years, well more than 100 years. But in recent years, with the fracturing of our media environment into all of these different kind of siloed areas where, depending on your political beliefs or, your worldview or perspectives, you can inhabit a media environment that just supports those beliefs. And the problem with this is that it has played a role in it not just spreading vaccine misinformation, but immersing some media consumers in that misinformation and disinformation and closing off opportunities for them to get good information from the media because they're living in environments where the algorithms behind the news that they're getting on their phones are simply giving them more and more of what they already looked at. And these algorithms are not designed to necessarily deliver information that's going to contradict things. So in other words, if you're a vaccine supporter, you're going to get a lot of news about exactly that. And if you start to show through your searching or your reading habits that you have concerns about vaccines, you're going to get more and more fuel for that internal fire.
It's an example of the increasing polarization more generally. Well,
Absolutely.
yeah. Well, thank you so much, Dr. Conis. That was fantastic and valuable. And for anyone on the call, vaccination is a fantastic entree to vaccination and to this all these contested domains of where politics and culture and society meet. I get to hand off now to Dr. Johnson.
Hi, everybody. So correction, I'm not a doctor, so I will clarify that, but I am an epidemiologist, which I feel like is the new term this day post-pandemic. Everyone's heard of an epidemiologist. Everyone's a backseat epidemiologist these days post-pandemic. But so what I want to do is I see there are a number of questions coming in, and I do want to respond to a few of those. I'm also going to share, if I may, and we'll see where we're at. And let me get this going. Because what I wanted to talk about was Massachusetts and what we see in Massachusetts if we were to have a case of measles, how local health would respond, et cetera. So my name is Hillary Johnson. I am an epidemiologist at the Massachusetts Department of Public Health. I am in the Division of Epidemiology in the Bureau of Infectious Diseases. And so what we do is we work to prevent infectious communicable diseases statewide 24/7, everything from foodborne illness to mosquito and tick-borne illnesses to vaccine preventable diseases to emerging infections like Ebola, Mpox, et cetera. And we monitor and investigate and respond to outbreaks, working with your local health departments to ensure public health. So, everyone's been talking about the national outbreak. So I want to just kind of level set a little bit and make sure that we understand that as of today, I checked with my colleagues just before this presentation, we still stand with no currently confirmed measles cases in the state of Massachusetts as of today. That said, we are seeing measles across the country, right? And so you can see this map from CDC. We have 1,168 reported cases, confirmed cases of measles as of last Thursday. So, this is definitely an undercount. There are cases that don't receive positive lab tests and don't get officially reported. But in general, I want you to think about this compared to last year. So we're looking at last year in 2024, there were 285 confirmed cases nationally. So I think in the news, we're thinking a lot about Texas and the Texas outbreak, which is certainly the majority of cases, but there are about 14 outbreaks happening. Some of those are from spillover from Texas and have started their own outbreaks in other places, but some are from other travel, other associated issues. So, but what we are seeing nationally is about 12% of cases are hospitalized, and there have been 3 confirmed deaths. 2 of those were in children, and they were all in unvaccinated individuals. So the cases that we see nationally are about 95% are confirmed unvaccinated cases. So how would we know, or what happens in Massachusetts? How do we know, and how would we follow up on a case? So there is this list of reportable infectious diseases. It's in the regs. You can Google it. It's 105 CMR 300 if you want to know what's reportable in the state of Massachusetts. But the long and short is it requires that doctors or labs or local boards of health, if they identify these cases, they're supposed to report them, and we do this follow-up, this universal kind of follow-up and surveillance. Measles in particular is particularly important and has some strict rules about what we do. So the point at which you are sick and you go into the doctor's office and the doctor looks at you and says, I think this person looks like they might have measles. At that point that they start to consider measles in the differential, as we say, they call us. They call us at the state health department. And we talk with the doctor and do a risk assessment and talk about symptoms. We talk about risk history. We make sure that the right specimens are collected for testing. And then we make sure that those specimens go to the state public health laboratory. And then depending on the risk assessment and everything that we have kind of gathered from the situation, we start to implement public health actions. And the reason we help doctors kind of at this level is, based upon those numbers, I think if you go to most doctors nowadays, if they're kind of maybe mid-career or earlier career, they're probably not seeing measles day to day in the office. And so they need a little assistance to kind of talk through. They might not have seen a measles case before in their medical career. So we kind of help start that process of figuring out, is this a high risk situation for measles or is it a lower risk situation for measles? So we're asking about the patient's vaccination history, their symptoms, and additional risk factors. And we kind of put that all together in this investigation to determine, are we really thinking that this might be measles? Do we need to start acting right away? Or can we pause a little bit and wait for test results? So things that would make me start to worry that the situation might be measles is if the patient themselves is an international traveler recently, they've recently traveled, been abroad, or if they've recently traveled domestically, been in an area where there's a known confirmed case, if they've been around people that have similar measles symptoms that were sick, if they are themselves unvaccinated, or maybe they have a childhood history of vaccination abroad where we're not as sure necessarily about records, but they think they might have been vaccinated. When people have maybe a history of vaccination abroad, we're not quite as certain about what they may have received and when they received it. And then also how they present. We think of measles with this rash, but it's a respiratory illness. So we're also looking for really high fever. We're looking for cough, cold symptoms, conjunctivitis, things along those lines. And those are all things that make me think, this might be a higher risk situation. Lower risk situations, patient was born here, they haven't had any travel, they're fully vaccinated with MMR. When I hear that, I think that's great. Less likely that we're going to be dealing with measles. Sometimes when they're sick, they have a positive test result for something else already. They might also test positive for flu or something, which could be an indicator that it's not going to be measles. Their symptoms are atypical for measles. They aren't presenting that rash in that classic way, or those other symptoms in that classic way. And something that happens a lot lately is there might be another reason for their rash, like they're taking additional medications. So often when we're talking with the doctor and they've got the patient there and we're kind of doing this interview, we might find out, can you ask them if they've taken anything else recently? The doctor will ask, and it turns out, oh yes, they're also taking some antibiotics or something else. There just might be an allergic reaction or something else that could cause that rash, which makes me think, okay, there are some other things happening here. It's a little lower on the suspicion for measles. But all of that information comes into play. We collect the specimens, and then our public health actions start while we're waiting test results, depending on how high risk the situation is. And the reason we want to know and get test results right away and put all that information together is because, as was mentioned before, measles is highly contagious, right? It's a contagious respiratory virus, which is airborne. And just to describe what I mean by that. So if I had measles and I was infectious and I walked through this room and I walked down the hallway and I left the building. All right, if anyone else came through that hallway or walked through this room in the 2 hours after I left the building, we would still consider that person to be potentially exposed to measles. So it's just highly, highly infectious, and it can find people. So we really want to get in there and get quickly, assess the situation, interview that patient who has tested positive and figure out where they've been while they were infectious. And you are infectious with measles from the 4 days before your rash even starts through the 4 days after. So we're potentially dealing with 9 days there where someone could have been exposing other people. And then the follow-up starts. And as you can imagine, if it's so highly infectious, we may see situations where that person went a number of places and a number of people have potentially been involved and been potentially exposed. So these are just examples of press releases that we've had to issue in the past. I will say we've had scenarios where people are traveling, they're visitors, or other situations where certainly if they're a tourist or they're visiting the big city, Boston or something, we've had people they continue, they want to get that tour in, even that they're starting to get sick or their family's kind of dragging them around, and there's a lot of potential to go a lot of places. I've also had a case that themselves, they were an adult, they were a grad student, they were starting to get sick. So what did they do? They quickly went out and ran all their errands because they could tell that they were getting sick. So they went to the Trader Joe's and they went to the Target and they went and did all these other things because they wanted to kind of buckle down and rest for the rest of the week. And they knew that something was coming. And of course, then they tested positive for measles, and we had all of these exposures that we had to follow up on. So once we've kind of confirmed the case and we're talking with the case and we're interviewing them about where they potentially went, we want to start to identify contacts. And those are all the people we could consider potentially exposed to measles. There's some really obvious ones. There are households, contacts, they're your close friends if you were at school, if you were at work, etc. And then there are the not so obvious ones. Just think about where you went this weekend. Could you recall every place that you went? And then additionally, can you recall how you got there? That's also a really important factor. So did you take the T? Did you take a taxi? Did you take an Uber? Did somebody drive you? Did you drive yourself? So we're working, trying to find not only where people went, but who they went with, how they got there. I will say the most common scenarios that we're looking at pretty much for every situation would be household contacts, the people that they live with. We would consider those people exposed, and there often are household contacts that have been exposed. And then often a medical facility, people go to seek care in a medical facility. And then we often have a medical facility exposure that we're also dealing with, be it a waiting room or something else. Now, I think we're all familiar with the word quarantine post-pandemic, but in general, if you or your child are not immunized, you may be advised to stay home, quarantine away from work or school, et cetera, in public places for up to 21 days after your exposure to ensure that you or your child do not become a case or become infected with measles and then potentially expose other individuals. And how we get that quarantine period of time for measles, that day 5 through day 21, is we look at all the literature, we look at all the data. And what we know is that the very earliest that someone might start to develop measles after they were exposed, the very earliest point is 5 days. And the very latest point that we've seen in the literature is 21 days. So between that 5 and 21 days, that's the incubation period. That's the average incubation period. That's the duration of the incubation period. And so what we want to do is we want to quarantine somebody if they are not immune and don't have evidence of immunity to measles, because that's the minimum and the maximum amount of time that they could potentially be incubating and may become sick themselves. And if we've already got them quarantined away, then we're reducing them potentially exposing other individuals. So when we find out this information, we want to act fast as public health. We're immediately trying to identify people who may have been exposed because we have some public health interventions that we can do, and definitely quarantine is one of them. But if we act fast enough, we can give people MMR vaccine within 72 hours of exposure, and that may provide protection and prevent the need to quarantine themselves. So if we can get in there right away within that 72 days, we may eliminate the need for quarantine from someone. And certainly, obviously in this day and age, staying home from work, staying home from school, you have caregiving duties, et cetera. These are all really important reasons that you don't want to quarantine if you can prevent it. But in addition, we don't want people to get sick. There are certainly, elements of that as well that we want to prevent. We want to prevent disease. So here's as kind of like a quick version of measles cases in Massachusetts over the last 10 years or so. And these numbers are low. These numbers are really great. They're low because we have a relatively well-vaccinated population in the state of Massachusetts in many areas. Certainly, we have pockets of under-vaccinated groups, but certainly you compare us to other places in the nation, and we're a really well-vaccinated group. But even though these are confirmed cases, even though these numbers here are low, that doesn't mean public health isn't doing a lot of work behind the scenes. So even for every single case up there, there are a lot of investigations that we do. So investigations could be things like we're following up. We've got that doctor call and there's a high risk situation and we're following up with their family and we're getting test results and we're getting the right specimens to the state lab and we're doing all this stuff and we're trying to rule out measles and we're able to do that, which is great. It wasn't measles that was making them sick. So there's a lot of work that still goes into this stuff behind the scenes that your local public health is working on that you may not see in the headlines or in the news releases. But I will say a couple of things related to these numbers and kind of anecdotal, scenarios and things that have happened in Massachusetts and elsewhere. We have had cases where, just to talk a little bit about how infectious measles can be, we had a young child under 1 a few years ago that was ill and was tested positive for measles. And through our investigation, we were able to determine that they had been in the Caribbean for vacationing with their family and had been in a kind of a hotel room. And we were able to determine that a traveler from France had stayed in the hotel room next to them. And they never interacted. They never were in the same room. But just that kind of level of being in a hotel room next to a confirmed case, measles was able to, that child tested positive for measles, unvaccinated child tested positive for measles, that the virus itself was able to find that child, that susceptible child, just to give you an idea of how vicious measles can be and how it can reach out and find people. So I like to wrap up with what I want people to do. I think it's always important to have an action item. So number 1, I would say get vaccinated. And then many of you probably are vaccinated or that in your history you were vaccinated. So my next question to you would be, could you find your records quickly in a pinch? Do you know where your vaccination records are? And could you identify that information? If public health was calling you because you had potentially been exposed, would you be able to find that quickly so that you don't have to quarantine and you kind of know that you're going to be safe? We work with a lot of folks that we have to give them ideas or helpful hints as to finding vaccination records. So we recommend things like If you went to school and seeing if the school still has your records, or calling your parents, looking in your baby book. Sometimes that was written down in your baby book, or other things like that. So there are some strategies that you can use to try and find your records. But if nothing else, you can definitely get the MMR vaccine. And sometimes that's best. There's no harm in getting an MMR vaccine, even if it turns out, oh, I did eventually find my record and I had been previously vaccinated. And I think in the questions I did see, it's very common for you get the rubella component. You get a titer when you are pregnant to see if you're immune to rubella. And so it's very common then if people have a negative titer, or a titer that didn't show immunity after birth, that people might get another dose of MMR just to kind of boost that immunity going forward. I'm open to questions, but I did see some Q&A in there. So I'm just put this extra slide up because I know folks were confused about rubella, rubeola, roseola, all these words, they kind of overlap. So the key here is that the MMR vaccine prevents both measles and rubella, which are both rash illnesses, but they're not the same virus. So measles is a virus that specifically affects the respiratory system, more severe and more life-threatening. Rubella is a virus that more affects the lymph nodes, eyes, and skin. It's generally milder, but it's really, really, really bad in pregnant women. That's why your doctor checks you for your rubella immunity. It can lead to stillbirth, birth defects, etc. So measles, highly contagious. It also is known as rubeola. That's where these overlapping words come in. And then rubella, not quite as contagious as measles, but it's also known as German measles. And so there's a little bit of overlap. And then I like to throw this in there because I get called about rash illnesses all the time. Another one that sounds similar, has nothing to do with these, is roseola, which is totally different. But it's a common viral infection that children get that can cause high fevers and rash. It's generally self-resolving, mild illness, and can be caused by 2 strains of the herpes virus. So there's a lot of overlap here. But when we're talking about German measles, or if people had talked about that historically, we're talking about the rubella. Measles itself is different than rubella. I think that covered a couple of the questions that I saw in the chat, and I'm happy to answer any additional questions. So I'll stop sharing now.
Yeah, so folks, let's give a big virtual round of applause for our panelists. They did a wonderful job. And folks, they finished right on time because now we have 15 minutes of audience questions and comments. So if you haven't already, please type your comment or your question into the Q&A box or the chat box, and we will get rolling. Okay. First question, I'm going to take liberties and ask the first question, and this is breaking news. Just a couple of hours ago, Secretary of Health and Human Services, Robert Kennedy, announced that he was dismissing the entire, let me see if I get this right. Oh boy, here we go. I'm not good with acronyms. So this is called the Advisory Committee on Immunization Practices. It's a 17-member committee which advises the U.S. Centers for Disease Control and Prevention on the vaccination schedule and required coverage of immunizations. And apparently he's going to replace all 17 members within the next couple of weeks. And this is causing quite a stir. I guess when he was going through the nomination process, he said he wouldn't be doing this. And so several Republicans who voted for him, including Bill Cassidy and Susan Collins, are already expressing public concern. So this is a bipartisan issue here. And so I was just wondering if anyone wanted to reply, any comments regarding today's breaking news.
Would you mind if I put that in a little bit of historical context and then maybe pass it to Lewis and Hillary? That committee was first created in the era of the measles vaccine in the 1960s. And it was created because the federal government was getting more involved in kind of determining the direction of vaccination policy for the country as a whole. Before that, there were fractured vaccination recommendations coming from the public sector, the private sector, state, local governments, federal governments. And so the advisory committee was created to kind of create a unified set of recommendations that could be followed all across the nation. But as we entered that era of slowly mounting vaccination resistance in the later 60s, 70s, and 80s, that committee actually became a focus of vaccine critics who said, why should that committee have only experts? Let's please add some consumers and members of the public. And so in the 80s, they succeeded in opening up the committee more. And then after the 2000s, those positions were I'll say modified a bit so that vaccine skeptical groups felt like they were no longer represented on the committee. What I'm kind of getting at is that that committee has been a locus of attention and has been a site of our disputes over vaccination politics for a solid almost 65 years at this point. So it is, in historical terms, not surprising to see today's turn of events.
Louis, did you want to comment?
Yeah, okay. So as a pediatrician, yes, maybe a different slant on things. First of all, I did read, thank you, Robert, had a chance to read that report, and the secretary brought up conflict of interest as a major problem. And it is true that the people on this committee are going to have contact with immunization, vaccine producers, because that's their life of studying vaccines and how they're made and how they're produced and the side effects and the intricate data of controlled studies and how do you say the vaccine might be 50% effective, 90% effective, and so forth. So it's complicated statistics, and it does involve understanding the vaccines and how they're made as part of that, and working with vaccine companies as well. And conflict of interest is very important, and that's part of science. It's part of science to actually declare your conflicts of interest. Every time you write a paper, everything you do in science is to declare a conflict of interest. Politics does not have to declare a conflict of interest. So there's a separation between science and politics. And so politicians, it would be, I think, impossible for them to declare their conflicts of interest, who's given them money and they made a certain decision on that basis or something. So I think that nobody's free of conflict of interest, but I think that if you have to explain in exposure what your conflicts of interest are, I think that is an important step that we are taking, and what this committee does do in their deliberations. So nobody's perfect. They've got, I think, Elena, that was great. I wasn't aware that exactly when consumers or parents and patients became part of that. But of course, that's a way. Much more in medicine, we do need to involve the patients and the people that we're working with. We've got to hear from them, and we need to involve them. I'll just say quickly, the Massachusetts Medical Society, where I'm involved, has added to their elite board of trustees at the very top, their first consumer, an individual who speaks well for people, the underdog, and parts of society that are not maybe heard when it's all physicians around the table. So that's happening, maybe not fast enough, but so I think this is, I have to say, just a political statement. It's not related to science. I think people will have to start making their own decisions now, as Elena is saying, and read multiple sources to figure out what is the best path for them.
Did anyone else want to weigh in on today's news before we move on to further questions?
I'm just going to say it's not good. We can move on.
Yeah, okay.
Hillary, I did want to ask you a question. So I would say 25% of the questions we've received so far kind of revolve around the same thing. Folks who got the vaccine when they were a child, maybe in the 50s, 60s, or 70s, are now wondering if they're still protected from infection. Do they need a booster shot of sorts? So Hillary, and I know you touched on this actually in your presentation, but just to reiterate the point, would you like to answer that?
Yeah, I've seen a couple questions. So there is a clinical advisor, which I'll try and put in the chat, that people can check. And there's a Q&A that DPH put out. And so if you for your particular age and scenario and timeline of when you may have been vaccinated or think you were vaccinated, you can check it and see what is necessarily recommended for you. a couple common questions that we do get. People ask, should I get a titer? So to explain a titer is essentially a blood test, right? A blood test, you get your blood drawn, and then the laboratory will test your blood and look at the level of IgG antibodies for a particular, vaccine and virus, and see if you have a high enough, you meet this high enough threshold, your test results are high enough to say, like, yes, we would consider that person to have high enough antibodies to that, and we think that they're immune. So if you thought, hey, I don't know about my MMR vaccination status, I want to get a titer, technically you could get that done. But remember, there are three components of the MMR vaccine. So there's measles, mumps, and rubella, and you would need to run a titer for each of them, one for measles, one for mumps, one for rubella. You can do that and wait for the test results. It's not always covered by insurance. I think that's one of the biggest issues, is that it's not always something that's cheap. It can cost you a lot of money out of pocket. So it really depends. Sometimes it's easiest and best to just get that MMR vaccine. If you don't know, to just go ahead, and you are eligible to get it, to go ahead and get the MMR vaccine. There's no harm if for some reason you later find out, oh, I did find a vaccination record from 30 years ago, I did have an MMR dose, et cetera, to get an additional dose. People get doses for travel. People do all sorts of things. So it is okay to get it may be easier. And then the other thing I will say, if you did get a titer, like if you did pay for the blood tests and the blood tests did come back and then they said you were non-immune, you'd have to go back to the office to get the vaccine anyway. So then you're paying for potentially 2 visits to the doctor's office as well as those test results. So sometimes it's easier, faster, most efficient to just get that dose, and then it's on your record and you're good to go.
And a follow-up from Catherine, does receiving the MMR as an adult have any concerning side effects I should be aware of? That's to you, Hillary.
We'll have the doctor answer that.
Pregnant women are not advised to take the MMR.
Yeah. So did I say that? Did I say that they?
You said that.
Oh, sorry. I meant a post birth, people might get an additional dose. Sorry, just to clarify. Yes, I'm sorry if I said it like that. I meant often when you are pregnant, you get a blood test, you get a titer done, to see if you are immune to rubella. But if it comes back negative that you aren't immune, you're watched through your pregnancy. And then after you've given birth, you can get that MMR dose to make sure that you're covered going forward. So I apologize if I was not clear about that.
So this question next is from Diane. This might be best for Elena and Lewis, but again, whoever wants to answer can answer. So Diane says, when I was growing up in the 50s in a Massachusetts city, it was not uncommon when a neighborhood child came down with measles for mothers to bring their children to the sick child's house so that their kids could catch measles and get it over with. Was this practice common and widespread?
Yes. And in fact, it was common and widespread for hundreds of years. And in fact, people often did that with smallpox, a much more serious disease in the pre-vaccine era. And so what I really want to emphasize about my answer to this question is that this was a practice that made a lot of sense when prevention wasn't possible, but controlling the means of infection was. So in the, pre-smallpox vaccine days, people knew that getting smallpox as a child was far less risky than getting it as an adolescent or an adult. And so they might deliberately expose a child or sometimes even an adult to smallpox to ensure that they got the infection under controlled conditions, because the observation was if you got it once, you were protected for life. And this was something that was done with measles too, also for a long time before the pre-vaccine era, and based on a lot of the same assumptions. If you got it as a child, it was usually milder. And if you controlled the means of infection, you could deliberately infect yourself by exposing yourself to somebody who didn't have that serious a case. This was done with other diseases too, I'll mention. Chickenpox it was done with too, up until the era of chickenpox vaccination. And these were called chickenpox parties. Sometimes they were called measles parties before that. Nobody ever called deliberate infection with smallpox a smallpox party. But there was actually in certain parts of Europe in certain centuries, entire industries or sub-industries of the healthcare industry that specialized in providing deliberate infection with smallpox.
Yes,
Yep, go ahead, Lewis.
Yeah, that's my day. Thank you, Elena. I wonder what was going on in those days, those parties. The main party I remember was for the German measles, and that was to try to make sure that all the children got German measles so that it would not spread to their mothers or their aunts and so forth in society, and cause fetal abnormalities. And that was one thing we did see in pediatrics in the 60s, and were just terrible results from the 3-day German measles affecting pregnancy and fetal development. Yes, and when there was no way to, these parties involved healthy children, solid families, nobody's got leukemia or anything. I mean, these were picked out people that were most likely to survive this measles. So yeah, nobody wanted to get measles. You didn't want little kids to get measles, and you didn't want older people to get it either. But in those days, because older people did not have the benefit of the vaccine, which is lasting a long, long time, Hillary. Ever since the 60s, that those 2 shots are still good for this one disease. Think of COVID, all the different kinds of shots that are being developed for COVID, and that same shot's still good for measles.
Yeah, I'll just add to that. There are certain viruses that mutate and they change a lot. We talk about the flu virus, et cetera. That's why we're getting new vaccines every season, because there's new, the virus mutates, it moves, and there are other strains and stuff. Measles is one of those things that has stayed the same. It has not changed over time. So the MMR vaccine is really good. There is a slight cohort, which I put the link in the chat. So if folks, there's a slight cohort of like one particular year, they estimate like 100,000 or so doses that were not great in like the 60s. And people may worry if you were in that cohort that you should get another dose, et cetera. But in general, yes, the MMR vaccine is really good. If you had 2 documented doses of MMR vaccine, you're good to go. So I'm also seeing some questions about people who say that they had childhood disease or they had disease in their history. So what should they do? So I'll say a couple things on that. In general, we think there was a time, as everyone's been talking, where measles was much more prevalent. And the likelihood if you were born before 1957, you probably had childhood disease. We think rates were high enough that most people were probably exposed to measles at some point in time if they were born before that date. So in general, if you're in a low risk setting, you're not a healthcare worker, et cetera, you can go based upon year of birth that you are probably immune to measles. That doesn't mean you can definitely get an MMR. Nobody's going to stop you. That said, remember the MMR covers 3 different things. If people feel like they had, childhood illness, just, as we're talking, we're saying measles, we're saying German measles, we're saying rubella, et cetera. All that to say, sometimes, there's not necessarily a guarantee beyond that date of birth. Like if I'm 40 and I say, I think I had measles in my history, I would say, do you have a laboratory result? Do you have something that we would actually use as confirmation? And if you do, that's great. And so if you have a history of disease, what we would want to know is, do you have a lab test that proves that you had measles because you've had it more recently? And we would use that as evidence of immunity. But if you don't have year of birth, like if you're not born before 1957 and you don't have something on record, like a lab test saying that you did have the disease, there's not really a great guarantee that you did. And so in that sense, it may be better to get a vaccine on record. And I will also say, remember, the vaccine covers 3 viruses. So even if you had one, that doesn't mean you'd necessarily be immune to the others. So getting the vaccine would help in prevention of those 2 other diseases as well.
Ed, so first of all, we're going to start to wind down, take maybe 5 more minutes of questions. Ed has written, I'm going to say, a half dozen great questions in the Q&A. And I'm sorry, Ed, we're not going to get to all of them, obviously. But let me try to ask at least one of them. Ed wants to know, Hillary, this would be for you. Does Massachusetts have a vaccine registry that persons can request a copy of their vaccination history?
Yes, we do. So there, we have the MIIS, the Massachusetts Immunization Information System, the MIIS. So that is essentially a database that any vaccines now that are administered are required to be recorded in there. I will say it is not, it doesn't go back to the 60s, right? It doesn't go back to the 80s, et cetera. It's something that has kind of grown, and new providers have kind of linked in as if basically if you have been around for electronic medical records, there's a better chance that your vaccine is going to be in there. But if you were going to the doctor when there were paper records, your records are probably not going to be in that system. But it is the MIIS, the Massachusetts Immunization Information System. You can look online and you can request to see what they've got and request your record. Absolutely. But again, they might be missing some of your historical data if you were vaccinated a while ago. I would say since the pandemic happened, this system has been really good about, and all providers, all medical providers and offices have gotten on this system. And now anything, CVS, all those places are probably going to be showing their vaccine, vaccine records are going to show up in this system and you could request it. It's a great database, but it's might not have kind of larger historical records in there. You might have to look at another source.
Did anyone else want to weigh in on that one? And nope, yep. And so last question goes to anonymous attendee. How can we track measles outbreaks in this country and in other countries? Are there websites to go to follow measles?
Yeah, CDC's site. I would Google CDC measles, and you'll kind of come up with their page, their outbreak page, and the WHO also shows kind of global measles outbreaks. So the data that I do in the state of Massachusetts, like all other health departments, all work and report our data to CDC, and CDC kind of puts up a general page and kind of reports like weekly data. And for measles in particular, they have an outbreak page. They're publishing every Thursday the last week's data. So that's a requirement. We report that information and you can see it there. CDC has been kind of cleaning up their web pages, so to speak, lately, but that information is there. And you can definitely find it. If you Google CDC measles, morbidity rates, any of that, you'll come up across that page.
Go ahead, Louis.
I just wanted to make an overall view about Elena Conis's book, Vaccination. I think what she is telling and showing me, at least, is the life and health of children has been changing over the years. And this has been the result of certainly parental involvement and many forces at play. And I just went to AI and looked at infant mortality rates just to show that we're in a wonderful time right now. And that's what I think is coming out of that book, that we can take care of ourselves, joining with science and with the book that she refers to, Our Bodies, Ourselves. We can join together. And these infant mortality rates are unbelievable because around 1960, when the vaccine came out, it looks like the rate was about 30 infant mortality rate. That's 30 deaths per 1,000 live births. And of course, that's the United States. It was much higher than that in many places around the world. But it has gradually gone down now to 4 or less. So over these years, and it's been a lot of things, infant neonatal intensive care units, all kinds of things that relate to infant mortality. These shots mainly are given during infancy at a time when children are exposed to these diseases. So this is an important part of that infant mortality picture, which has resulted in children just living their lives to the fullest and having these advantages that did result from society itself, public health, medical, a better educated society. Many factors went into this, that children are now really at a stage of wonderful survival that they didn't have 30, 50, 80 years ago. Thank you. Thank you, Elena, for that contribution.
Yeah. So let's do this before we wrap up. I didn't tell the panelists I was going to do this, and hopefully we're not overstaying our welcome, but I'll give each of you 30 seconds and let us know if you have any words of wisdom you want to leave us with, any last words for the audience, any maybe one key takeaway you'd like us to have from tonight's webinar. So Hillary, I'm going to put you on the spot. Any last words for the audience?
I would say look for your records, get up to date with MMR. I think there's the quickest and easiest way may be to just get an MMR if you can't figure out what your vaccination history is. And I want to say one quick thing about measles. There is a general idea among some people that maybe, getting a particular disease is better for immunity than getting the vaccine. And I want to say in particular something about measles itself. Measles is a really vicious disease. It does a lot of different things to the body, but in particular, one thing that it does is it can erase your immunity to your immune memory, your immune system in many ways, to not just measles, but to other things that you may have developed an immunity to before. So we have seen this in measles cases. So you're not necessarily helping yourself by thinking the disease would be better than the vaccine itself. You may be losing immunity to other things that your body has built up because it kind of erases your immune system to a certain degree. I just wanted to highlight that, but thank you.
Great, thanks, Hillary. Alana, anything you want to leave the audience with?
Sure. I will say that going back to our point about the media, we live in such a polarized media environment and such a competitive media environment in which we, no matter our vaccine views, are exposed to stories that are designed to cultivate kind of our fear and our anxiety. And I find that history can be a really helpful antidote to that. That if you know the broader context of where we've been and how we got to where we are, it can kind of help allay some of the kind of panic that is stoked by contemporary narratives that are just designed to get our kind of laser focus on the problems of the present. This is not in any way to diminish the problems of the present, but to kind of understand that we're dealing with problems that we have in some cases seen before, and in some cases seen in slightly different forms before, and that we aren't here kind of by accident or by a sudden turn of events, but by a series of things that have been unfolding for decades and in some cases centuries.
Thanks, Elena. Scott, any last words from you?
Just as a local plug and building on what Elena had said, for folks who are interested in considering how the history of medicine has framed and informs our current situation, come to the Public Health Museum. You'll see exhibits that will frame this, whether it's related to measles or polio or nursing. This allows you to start thinking in those ways. So obviously, you're all certainly invited to the museum.
And by the way, if you ever visit the museum, the Tewksbury Library is about 60 seconds away, right up Hospital Road. So feel free to drop by the library and say hello to me. Louis, last words.
Okay. The immunizations and so many other facets of child rearing are essential for the health of children to be discussed and to be discussed with trusted sources. It doesn't really matter what's going on in the political world. Hopefully people have a trusted physician, nurse practitioner, family doc, have a trusted source to go to, a neighbor next door or something that you can trust and believe what you need, the kind of information you need, and do appropriate reading so that you can come to the best decision to save your children from illness, injury, and all the things that can diminish life expectancy. So it's in our hands as parents, educators, historians, pediatricians, and all of us to work with parents and help children to have a safe and healthy and long lifespan.
Great. So folks, let's give our panel another big round of applause for a great Q&A. Thank you so much for joining us tonight. Look for an email from me later tonight with a link to the recording, as well as information about the Public Health Museum. Please take the feedback survey when you exit the Zoom. Thank you so much, Louis. Thank you, Hillary. Thank you, Ilana. Thank you, Scott. I hope everyone enjoys the rest of their evening. Bye-bye.
Bye. So long.
Bye. Thank you.